Hello, I'm Professor Chris Deary. I'm Professor of Paediatric Dentistry here at the University of Sheffield. Today I'm going to deliver a talk on key statistical principles as part of the Research Methods module. The aims and objectives of this talk are to explain the concepts of diagnostic validity, reproducibility, power or sample size calculations, and the influence of confounders on research. I'm going to start by using an example from my research area so we can actually build on an example. So the question I'm going to ask is a laser fluorescence device useful in caries diagnosis? Here we see two examples of a laser fluorescence device used for caries detection. And in the lower picture we see the pen device being placed between two teeth and the laser is being admitted, the tooth fluoresces, and then the machine takes a reading which then can be used to calculate whether the tooth is carious or not. So that would lead us to this null hypothesis. Is there any difference between a laser device and visual diagnosis for caries detection? So I'm going to ask you to think about some of the previous modules you've done, and let's start by thinking about what factors we would take into account when thinking about the sample for this study. So I'll just give you a few moments to do that, and then we'll talk through the things I think we should consider. So I think age. Are we going to use adults? Are we going to use elderly people? Are we going to use young people? And that links later on to whether we use primary or permanent teeth. Similarly, in the image I showed you, we showed it being used for interproximal caries, but we may decide that our study is more interested in root caries, our study is more interested in occlusal caries. If we're doing an in vitro study, we would actually maybe want to know about the fluoride history of our sample. Do we do it in an area with natural fluoride or not? And obviously that has big implications. We also need to think about the severity of the lesions. Are we going to look at enamel caries or dentine caries? Again, that's a choice depending on the research question you're asking. Sample size. How many teeth do we need to look at? And that I discuss in more detail towards the end of this talk. And there's ethical issues. You know, one example of that would be we would possibly need to exclude children who are in pain because we can't delay their treatment. And I'm sure you can think of other things. So how this study was actually carried out is we had 3 examiners, because that allowed for examiner variation. And again, later in the talk, I consider how we assess examiner variation. These examiners examined teeth, and these examiners used the pen, and then we histologically sectioned these teeth so that we could find out what the correct answer or how valid each method was so that we could compare them. And again, we will discuss that further. So that brings us to diagnostic validity, also known as your gold standard or a validating criteria. If we stick with the study we've discussed so far, we might have used radiographs as a validation, or if we could actually get extracted teeth, for some reason we would be able to do histology. And obviously histology is a superior method of validation to radiographs. And I'm sure you can think of other examples from other areas of research where you might choose between different validating criteria, but each one would have its advantages and disadvantages, and one of them will always be the best or the gold standard. When you look at your validating criteria, you compare that to your actual examination results, and therefore you can have a true positive, i.e. there was disease present and you correctly diagnosed it. False positive, there was no disease present but it was identified as being diseased. True negative, you identified a healthy site and it was in fact healthy. Or a false negative, where you incorrectly said a site was sound when in fact it was carious. You can put those states into this grid, and therefore you can have your gold standard across the top and your results across the side, and you have true negatives, false positives, and true negatives. And this allows you to do some analysis of your results. And the tests people frequently do to look at diagnostic validity are sensitivity, specificity, predictive value positive, predictive value negative, diagnostic accuracy, likelihood ratio, and receiver operating curves known as ROC curves. And I'm going to talk through what each of these terms mean and their advantages and disadvantages. So don't let this formula put you off. It's actually very simple, and it's just using that very simple table. Sensitivity is the ability to detect disease when disease is present, and that is calculated by putting all your true positives over all your true positives plus your false negatives. Specificity is the ability to detect a health when disease is absent. Specificity, again using that table, is true negatives over true negatives plus false positives. Now, people find these terms very confusing, and one analogy that I think helps is to think about a car alarm. If you have a very sensitive car alarm, if somebody tries to break into it, it will go off and it will stop the burglar stealing your CD. However, the disadvantage of that is that sometimes when someone's walking past at night, the alarm will go off and wake you up and all your neighbours. If you decide to have a very specific car alarm, it won't ever wake you up at night, but the disadvantage is that sometimes it won't go off despite the person breaking into your car and stealing your CD. And therefore, depending on the disease you're looking at, the balance between sensitivity and specificity becomes a choice. In caries, a disease that is not really life-threatening and is slowly progressing, you would tend to want a test that has a high specificity, because the disadvantage of diagnosing a healthy site and treating it is far greater than the consequences of not treating a diseased site. The opposite, say, would be true for cancer, where the consequences are very serious and the disease can be rapidly progressing. And in that situation, you may be quite happy to have a very sensitive test and accept that on occasions, healthy people are diagnosed as having the disease. Sensitivity and specificity are not affected by the prevalence of the disease. And when you think more about these two terms, actually don't tell you very much about the use of the terms in practice. And that's why people use predictive values positive, predictive value negative, and likelihood ratios. Although, as we will see, these are created from the same grid, these terms are affected by the prevalence of the disease and actually do tell you the likelihood that the disease, that the person you're testing actually has the disease. And I will explain that more in the next few slides. Predictive value positive is the odds that the test, when it says you've got the disease, that you actually have the disease. And that's calculated by true positives over true positives plus false positives. A good example of this used in everyday life, or almost everyday life, is a pregnancy test. When the manufacturers of pregnancy tests say that when it turns blue you're pregnant, and they say this is accurate 99.9% of the time, this is its predictive value positive, i.e. the chances that you are pregnant when the tester says you're pregnant, and the same would be true for diagnosis of disease. Predictive value negative is the exact opposite, and you see the formula here, true negatives over true negatives plus false negatives. And this tells you the chance that if the test says you're healthy, that you are in fact healthy. So you can see that's maybe much more useful to the clinician and the patient than the pure terms of sensitivity and specificity, because you can't turn them immediately into a meaningful number. But what they allow is for you to compare different tests in a pure sense, so you can actually see which is the best method overall. Likelihood ratio takes the term sensitivity and divides it by 1 minus the specificity, and this gives you an overall number which allows you to actually unite those two terms so that you can say which, if you were comparing tests, is better. The other thing a likelihood ratio allows you to do is, if you know the prevalence of the disease in a population and you multiply it by the likelihood ratio, you get the odds that anyone would in fact have that disease given the test. This is the likelihood ratio of a positive test, but you can in fact do the same for a negative. Receiver operating curves use the same principle of, on the y-axis, the sensitivity or the true positive rate, and 1 minus the specificity or the false positive rate, to allow you to compare different diagnostic methods and different diagnostic methods at different thresholds. So here we see 3 devices: the laser fluorescence device in red, visual examination in black, and radiography in green. And these are plotted on this graph, and the device which is nearer number 1, i.e. the top left hand corner of the graph, is the superior diagnostic tool, and this is known as the area under the receiver operating curve. People sometimes find it helpful with receiver operating curves to understand how these things were invented, for want of a better word, and it comes from the Second World War, when RAF radar operators were looking at these round screens with lots of dots on them, and they were trying to identify incoming German aircraft, but they got a lot of false images on the screens of clouds and just electronic feedback, and therefore there was a great skill in being able to identify whether it was a plane or whether it was a cloud. And these curves were used, these graphs were used to identify the members of the RAF team who were better at interpreting what they were seeing on the screen. And these operators of these screens were known as radio operators, and that's why it's an ROC curve.